Hi guys, can you hear me? Oh, great. Perfect. We'll make a start then. My name is Ashka. I'm an F1 working at the Royal Liverpool Hospital. I'm the president for Thursday 15, the teaching group, and we do teaching sessions every Thursday, covering different topics that come up in finals. Um, the reason why it's on a Tuesday this time is because I had an emergency for when it was scheduled to be last month. So I apologize for that. But hopefully today's session will be good and will be helpful for you guys. Right. So we'll make a start. Right. So this is the first question. So as usual, just give you guys about 1 minute and then we'll move on to the next question and so on. And then we'll go through the rest of the explanations. Next question. Next question. Next question. Next question.
Oh, sorry, I think Ashka has just had her internet cut out. If you can just bear with us for a sec, and hopefully she'll come back online in a moment. Well, it looks like Ashka is just rejoining now. So the question should appear back on the screen anytime now.
Is that okay? Yeah,
Perfect.
great. Next question. 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 And that's it. Well done for getting through the questions. We'll now go through the explanations. If you've got any questions, put them in the chat or the Q&A and Holly will answer them. Right. So this is the first question. I won't read the question. It's about a patient who's come in with fever and swollen, painful knee. So if we get the poll up. Lovely. All right, okay. So it's a bit split. That's fine. Let's go through it. So the answer is E. Take the patient to theatre for aspiration. Now, the reason for that, we'll go for each of the answer. So here, this patient has got 2-day history of fever, left swollen, painful knee. They've been unwell and they're struggling to wait there. So we're thinking this patient likely has septic arthritis. The thing that makes it E and not C, which a few of you went for, is the fact that he's had previous bilateral total knee replacements. So he's got prostheses in situ, so in his joint. So the issue with doing it in ED, does anyone know why we need to do it in theatre instead, the joint aspiration? If you can just put it in the chat. Yeah, great. That's great. So, yeah. So the reason why it needs to happen in theatre and not in the A&E department is because there is a risk of infection. He does have fever, he does have a swollen, painful knee, you are suspecting septic arthritis, so he probably already has an infection in there, but there is a very, very small possibility that he might not, and it might be one of the differential diagnoses. So you don't want to be introducing an infection in his knee joint in an aseptic area, so it needs to happen in theatre. Now, knee radiographs and x-rays, they wouldn't really show you anything, and it's an investigation, not a management. CT scan, same thing. This is an emergency. You wouldn't waste time to take this patient to CT scanner. We've explained why it's not C. If you're suspecting a patient to have septic arthritis with this temperature and they're tachycardic and this unwell, it would be IV antibiotics and not oral. So the most appropriate answer in this question is E. So septic arthritis, it's an emergency, and the reason is that there's risk of sepsis, which is the case in this patient, joint destruction if the infection is not treated, and osteomyelitis in patients who do not have a prosthesis in. So the way that it spreads or gets to the joint in the first place is, for example, if you've got a wound there, there's direct invasion from the surface of the skin, if there was an infection, and then if a patient has an infection elsewhere, for example, like infective endocarditis or dental infections, that spread to the blood and then gets to the joint. So that's the hematogenous spread. Clinical features, as we've described in the question, and they won't be able to wait there, they'll be in a lot of pain, and they will be systemically unwell. So investigations, the definitive investigation to make a diagnosis is joint aspiration, which is sent for CNS. And if it comes back with more than 50% polymorphonucleus cells, which is essentially your neutrophils, or more than 50,000 per mil of white blood cells, then you can safely say this is septic arthritis. If a patient's spiking a temperature, you will send bloods and blood cultures anyway. And the joint radiograph you can do, people usually do it, but it's not to diagnose the condition or to find out what it is. It's to find out the extent of the disease and whether it's gone to the bone or there's an effusion there. Management is usually antibiotics for 2 weeks IV first, and then 4 weeks of oral. And if the patient has a lot of fluid in the joint, then we do aspirations to dryness. Okay, next one. So let's put up a poll. Great. Right. Okay. So it's split between A and C. What I would suggest is to be very careful when you're reading the question. So the answer is C. Reason is, it says what would be the initial management step in this scenario. So this is a patient who is on the orthopedic ward, and they've got left tibial fracture, for which they've had surgery, and then their leg was placed in a long cast following the surgery. So you're asked by the nurse to prescribe more analgesia as they are complaining of worsening pain in their leg despite their current morphine dose. Now, again, this happens a lot in hospital, just to bear in mind. As an F1, you get asked to prescribe more analgesia all the time, but bearing in mind that if you're worried about a patient, like, you don't just prescribe the analgesia, you go see them and assess them. So On examination, they appear to be in pain and complaints of tingling in the toes. So yes, you're worried about compartment syndrome. Dorsalis pedis pulse is present. So it's still there. Given the most likely diagnosis, what would be the initial management? So the initial management would be to split the leg cast. So anything that's causing physical, mechanical compression on this leg, and you split that first. Not everyone who has these symptoms will need an emergency fasciotomy. Sometimes they will actually feel better once you've split that leg cast open. And especially in this case, this patient's dorsalis pedis pulse is still present, it's palpable. Once you've split the leg cast, you reassess, and then you see, and then you make a decision, do they need an emergency fasciotomy or not? But the most initial step here would be to remove the leg cast. So compression compartment syndrome, it's due to raised pressure in a certain muscle compartment or multiple compartments, and this is as a result of inflammation and muscle swelling, and this causes compression of your capillaries, which results in decreased blood flow and ischemia. Just to bear in mind that this compartment syndrome can occur in your lower limb, it can also occur in your upper limb, because you've got fascial compartments in your upper limb as well. Now, clinical features, you get pain on passive movement. So when you're doing the movement yourself on the patient, now the movement will depend on the movement on which they experience pain will depend on which compartment is affected. So if, for example, it's the anterior compartment which is affected, if it's the anterior compartment which is affected, so that means when you stretch the tendons of the muscles that are in the anterior compartment, this patient will feel pain. So essentially what you're doing is you're plantar flexing this patient's foot and you're stretching these tendons, and this will cause pain. So it would be the opposite if it was the posterior compartment which was affected. So that's what I mean by depends on which compartment is affected. And then you get the P's and pallor, pulseless, and paresthesia, paralysis, that's a late sign. And then management, as I said, remove any casts, anything that's causing compression, and then emergency fasciotomy. Okay, next question. Paul, if we can have the poll, please. Thank you. Okay. Right, so most of you got the correct answer, which is C. Great. So this patient is 80 years old. They have a comorbidity of heart failure, and they've also got dementia. So they had a fall, and now they're presenting with hip pain, inability to weight bear, and their right leg is shortened and externally rotated. So we're thinking they've got a hip fracture. What do you guys think of the X-ray? Is this intracapsular or extracapsular? Yes, it's intracapsular. So let's have a look at why that is. If you look at the X-ray itself and you trace the cortex of of this hip, you can see there's a break there, okay? And it's medial, or you could say proximal, to the intertrochanteric line. So this is what differentiates an intracapsular fracture from an extracapsular fracture. And so here, the break is here, and you can see there's a fracture there. So this is an intracapsular fracture. Now, it doesn't matter which type of intracapsular fracture it is in this case, in terms of the Garden classification, which we will look at. Reason is, this patient is 80 years old, she's got comorbidity of heart failure, and she's got dementia. So regardless of whether it's displaced or undisplaced, she would have a hemiarthroplasty, and she wouldn't be eligible for a cannulated hip screw or a total hip replacement. The reason why you can't give a patient with dementia a total hip replacement is because with a total hip replacement, there's some movements that patients should not do, like complete flexion of their hip, and with a patient who's got dementia, they might not be able to follow these instructions, and when they do, if they do it, then there's a risk of dislocation of this total arthroplasty. So let's move on and talk a bit about hip fractures. So these are just the different types of intracapsular versus extracapsular fractures. So intracapsular, you've got three types. This is the subcapital one in red, transcervical one in orange, and then the pink one is basicervical. It's right next to the intertrochanteric line. And then you've got the extracapsular fractures, which is endotrochanteric and subtrochanteric, and management for extracapsular fractures differ from intracapsular. So in terms of X-ray interpretation, it's very important to have a good method of doing it. So usually we use ABCS for bone fractures in general. So A is for adequacy or alignment. So this is where you look at the joint, you look at whether the X-ray is actually good quality, and you look at the joint space and the cartilage. B is for the bones. This is where you trace the outline of the bone and see if there's any fractures. C is for cartilage, and then S is for soft tissue. So you see whether there's any swelling, any blood or lipo, like blood or fat and stuff like that around the injury. Right. So this is another example of a hip X-ray. What do you guys think this is? Is this intracapsular or extracapsular? Yeah, great. Intracapsular. Lovely. So this is here. This is where the fracture is. And you can also look at Shenton's line, which is this line here. And it's normally, this would be intact if there is no hip fracture. But if you do it and then you see, oh, there's a break, that's Shenton's line's not intact, then you're suspicious for a hip fracture. So here's another one. What do you guys think this is? Yes, that's an intertrochanteric fracture. Great. Well done. So looking at the Garden classification, this is a classification just for intracapsular fractures. So type 1 is partial undisplaced. So it's just a partial fracture, not through, and it's undisplaced. Type 2 is complete and it's also undisplaced. Type 3 is complete, only partly displaced, and then type 4 is complete and it's fully displaced. So this has a consequence on the management choice that you will adopt for the patient. So let's look at that, the management. So intracapsular versus extracapsular. So for intracapsular fractures, if it's undisplaced, which is type 1 and type 2, then you move on and you see, do they have any comorbidities? So in Our Lady, she had heart failure and she had dementia. So yes, then they would go for a hemi-arthroplasty. If they don't have comorbidities, then you can do an internal fixation with cannulated screws. If it's displaced and they have comorbidities, again, you go for a hemiarthroplasty. If they don't have comorbidities, then they would meet the criteria for a total hip replacement. Extracapsular, so you've got two different types, intertrochanteric and subtrochanteric. So for intertrochanteric, you do a dynamic hip screw, and for subtrochanteric, it's usually an IM or intramedullary nail. So it's just easy to just remember these kind of flow charts, and because the questions they usually come like this. So they come with an X-ray for you to interpret, or they even just tell you what type of fracture the patient has, and you just have to decide on their management. So this is quite high yield. Right, next question. If we can have the poll up, please, Holly. Thank you.
Ashka, sorry, would you be able to just show the diagram of extracapsular fractures again?
Yeah, I can do that. Just give me a minute. So here, the blue line, this would be an intertrochanteric fracture, and here, this would be a subtrochanteric. I mean, I didn't have enough space here. Usually a subtrochanteric would be about 5 centimeters, within 5 centimeters of the lesser trochanter. But yeah, that would be a subtrochanteric around there. Is that all right?
That's great.
Okay. Okay. Lovely. Oh, the poll has ended. I didn't realize. Great. So most of you got the, oh, interesting. Okay, let's go for it then. So the question here is about a 30-year-old lady who is brought to the A&E department after a fall. As you can see there, she's got a fracture. Okay, so her right ankle is swollen. She's complaining of pain on palpation, limited range of motion. She cannot weight bear on the right foot. So you look here and you see a fracture. Do you guys know which classification we use for ankle fractures? Yes, it's the Weber's. And which type of fracture is this then? Is it A, B, or C? Okay, someone said A. It's actually C. So C, well done. So we'll go through the Weber classification. So the way we decide this is by looking at the tibiofibular syndesmosis, which is this area here. If the fracture is below this, then it would be a Weber A. If it's at the level of the syndesmosis, it's a Weber B. If it's above, it's a Weber C. So this determines which management option you're going to go for. A Weber C is usually a very unstable fracture. So normally what you would need to do in a patient with a Weber C fracture is surgical management. So they need internal fixation. Okay. Now, ankles are one of those joints where they've got an injury and it gets very, very swollen, especially initially. So you wouldn't do an emergency surgical fixation. So you wouldn't do it the same day because of the extent of the swelling. So the answer for this question is actually B. So it's surgical fixation after a few days. Surgical fixation because it's a Weber C, and after a few days because she's very swollen. So it's very swollen. So we wait for the swelling to come down a bit before we do the surgical fixation. So as we can see, D and E would be inappropriate here because it's unstable, and A as well, for the same reason, and C would be inappropriate because the ankle is swollen. Okay. So looking at the Weber classification, as I said, Weber A is usually below the level of the syndesmosis here, Weber B is at the level, and Weber C is usually above. So type A, it's usually a very stable fracture, so you can manage it conservatively in a cast, and that's because there's an intact syndesmosis and the deltoid ligament is also not affected. Type B is at the level. So this is usually in between Weber A and C. So usually intact, or the tibiofibular syndesmosis may be partially disrupted, and there may be a medial malleolus fracture. And the deltoid may be torn, but it's very, very variable, depending on to what extent these structures are affected. Usually if there's a medial malleolar fracture as well, they would be for surgical management in this case. Type C is above the level of the syndesmosis, with a disrupted tibiofibular syndesmosis. There's usually a medial malleolus fracture. I don't think we could see one on the last one, but it would still be a Weber C because you always look at the fibula to determine which Weber classification it is. And it was above the syndesmosis, so it is a Weber C. And that's unstable, always managed with surgery. Right, so question 5, and if we can have the poll, please, Holly. Right. Okay. Most of you got this right. And so this is a 57-year-old man. They are being reviewed in clinic for pain in the left hip, started a few years ago, usually worse on movement, and by the end of the day, experiences some stiffness in the morning. It only lasts for about 20 minutes and then it's fine. So given the most likely diagnosis, which would be unexpected X-ray finding, so the answer here is C, which most of you got. And the reason is because this presentation is very typical of osteoarthritis. It's important to know how to differentiate non-inflammatory from inflammatory conditions. Osteoarthritis is non-inflammatory. It's usually worse on movement and by the end of the day, compared to inflammatory conditions where usually they actually improve with movement. He has some stiffness, but it only lasts for about 20 minutes. It's less than 30 minutes. If it lasted for longer, then you could consider inflammatory like arthritis as well. So here the answer is subchondral cyst, because this is osteoarthritis. So this is usually because of progressive cartilage and bone degradation from overuse or just wear and tear. So X-ray findings, there's this mnemonic that we can use to look out for special features on the X-ray. So there's the osteophytes, which are kind of like protrusions of the bone there and there, which you can see there. Loss of joint space. So you will see that the head is quite close to the acetabulum, and this joint space is very minimal. It's very limited. Subchondral cyst, I don't think we can see one, maybe here, but essentially you can have subchondral cysts as well, and they appear a bit darker, and subchondral sclerosis, which would appear like very quite bright at the edge. So management, usually we start with conservative, so exercise, weight loss, and then with medical, you go up the analgesia ladder, and then we start getting into the steroid injections kind of area, and this is an option as well, particularly for patients whose osteoarthritis isn't quite as bad yet to need surgery, but it's not being managed with the analgesia that you're giving them. There are criteria for actually performing surgery in osteoarthritis. The issue is if you actually do a joint replacement when the osteoarthritis is not as bad to require the procedure, weirdly enough, the procedure is less likely to be successful and like reduce the pain and stuff like that. So usually it needs to be quite bad for a patient to have the replacement, the joint replacement. So next question, if we can have the poll, please. Okay. So there is a split between C and D, but the answer is it's C. So let's see why. So this patient is 70 years old. She had a low impact fall. Her she had a fracture from it. She had a DEXA scan, showed that she had a T-score of -3, which shows osteoporosis essentially. So she is started on a new weekly medication. So because it's weekly, you're thinking it's a bisphosphonate. Which of the following advice should be given when counseling? Bisphosphonate is a very common medication that comes up in OSCEs as well. So it's worth learning how to counsel a patient about it, because there's quite a few things to mention in your explanation. So usually the way you take bisphosphonates is you should counsel them to take it at least 30 minutes before their breakfast on an empty stomach. So before they've had anything to eat or drink. And after they've taken it, they need to remain upright for 30 minutes after. But the reason why D is wrong is because it says she should take it with breakfast, which is not true. It should be taken at least 30 minutes before any food. Yeah. It shouldn't be chewed before swallowing, and it would be in the morning and not evening or night. Right. So this is just a bit about osteoporosis. It's due to a reduced bone density, which increases the risk of fragility fractures. And there are several risk factors for it. So age is one of them. So above 65 for females, above 75 for males. Being postmenopausal, steroid use, history of fall, smoking and alcohol, and then other secondary causes like Cushing's can also cause osteoporosis. So usually on assessment, you calculate something called the FRAC score. You don't need to remember all the components of it. I don't remember all the components of it at the top of my head. It's just something to be aware of, knowing the FRAC score. And then when you've calculated that, it gives you like a risk level, and if it's above like a certain risk for osteoporosis, then you offer the patient a DEXA scan, if that's appropriate. So usually, if the T score, the DEXA scan will determine something called a T score, and if that's minus 2.5 or less, then you can safely diagnose this patient with osteoporosis. So this is just a bit about what we talked with regards to the bisphosphonates. Some side effects to bear in mind is heartburn, and particularly if they don't adhere to the instructions with regards to taking them and sitting upright and things like that. Osteonecrosis of the jaw. So you need to counsel the patient to look out for the symptoms of this, like facial pain and difficulty, chewing and swelling and things like that. So they need to have annual dental checks as well. So if their intake is inadequate, then you can give them calcium and vitamin D supplements as well. Right. So the next question, if we can have the poll, please. Lovely. All right, let's end it here. So most of you got the correct answer, which is D, so Perthes disease. So let's go through why that is. So we've got a 4-year-old boy, and they've been limping over the last few weeks. So it's important to bear in mind the age of the patient and also the time frame of the symptoms. So it's getting worse with time. Range of movement is limited, especially on internal rotation and abduction, which is typical of Perthes disease. And you do an X-ray of the hip and it shows sclerosis and fragmentation of the epiphysis on the right side. So the reason why this is Perthes disease is for what I've underlined in the question, essentially. So this is like the correct age group for Perthes disease. It's 4 years old to around 6 to 7 years old, and the symptoms lasting for weeks, and worse on internal rotation and abduction. So that's also indication of Perthes disease, and this X-ray finding as well. Now, what is Perthes disease? So essentially, Perthes disease is avascular necrosis of the femoral head. Now, this is just a table to summarize the commonest pediatric hip disorders that come up in questions in exams. So Perthes disease in particular is avascular necrosis. So they get persisting pain for a couple of weeks, and their X-ray findings, just important to bear in mind, and the sclerosis, the fragmentation of the epiphysis. So the way that you manage it is you can manage it conservatively for mild cases, but if it's a bit more severe, then they might need a plaster cast and they might need surgery. So why is it not the other options? So developmental dysplasia of the hip is something that usually will occur in infants or babies. So it's a hip joint abnormality where the head of the femur and the acetabulum, they do not articulate properly with each other in development, and they can dislocate easily. So that's why when a baby is born, you do the Barlow and Ortolani test. And this, if you feel like there's something abnormal on this test, then you investigate with a hip ultrasound, because this is a very young child. So the management can be conservative, again, if it's mild, surgery if it's severe, but the reason why it wouldn't be this in this question is because they would already have picked up on it earlier, and it's going to be more likely to be Perthes disease. Transient synovitis usually is inflammation of the kind of synovium sheath or like capsule. So that would be 1 to 2 weeks after a viral infection, usually an upper respiratory tract infection. The patient would present with a limp, low-grade fever. It's very important to distinguish this from septic arthritis, and we'll get onto that in a bit. And then the other option was SUFI, so slipped upper femoral epiphysis. This usually occurs in the adolescent age group. Usually in the question stem, they would tell you that this is a 14 or 15-year-old who is obese, and they've been having a limp with some referred knee pain, but you examine the knee is fine. So then you move on to the hip and you realize, oh, okay, so it's SUFI. So X-ray will show displaced epiphysis and a widened growth plate, and usually you need to surgically fix this to reduce the risk of avascular necrosis. JIA, juvenile idiopathic arthritis, we don't really know what the cause of this is, but it happens in children, and usually it presents with things like fever, malaise, and a pink thumb and rash, and you treat it like you treat other rheumatological conditions. Yeah. So in terms of septic arthritis versus transient synovitis in pediatric hips, do you guys know which criteria are used to differentiate these two? That's okay. So we normally use something called the Cocker's criteria. So this is just these 4 things here. So if you've got a child presenting with a bit of fever, limping, pain in the joint, so what you need to think is, are they weight bearing? So non-weight bearing, non-weight bearing would raise the suspicion for septic arthritis. ESR of more than 40, again, would raise suspicion for septic arthritis. A higher grade fever compared to a lower grade fever would make you think of septic arthritis, and a higher white blood cell count as well. So presence of one or more of these features would make you think more of septic arthritis compared to transient synovitis, right? So next question, If we can have the poll, please. Great. Lovely. Okay. I'll end it here. So most of you got the correct answer, which is D, Felty syndrome. So we'll go through why that is now. So this is a lady, she's come in with a productive grain cough and crackles to the left lung base. So you're thinking she likely has an infection, a pneumonia. She described an 8-month history of swelling and pain in her PIP joints, so the proximal interphalangeal joints, and that's bilaterally. She complains of morning stiffness lasting for more than 1 hour. So you're thinking about an inflammatory condition as opposed to a non-inflammatory. There's ulnar deviation and swelling of the metacarpophalangeal joint, your PIPJ swelling. And there's also palpable mass in the left upper quadrant of the abdomen. So blood tests are positive for ANA and anti-CCP antibodies. And then you've got these blood results there, and she's got a neutropenia, so of 1. So the reason why this is Felty syndrome is because the symptoms that are being described here is symptoms of rheumatoid arthritis, and also the positive anti-CCP antibodies also point to that. And then you've got a neutropenia as well, and you've got splenomegaly, which is the palpable mass in the left upper quadrant. So this is Felty syndrome. Now, how do you distinguish the seronegative arthropathies from a rheumatoid arthritis with regards to the joints that are affected in the hands? Now, what I mean by seronegative arthropathies, they are arthropathies where rheumatoid factor is negative. In rheumatoid arthritis, it will be positive. So usually in rheumatoid arthritis, your PIPJs are more likely to be affected compared to your DIPJs. Very rarely, or pretty much it doesn't happen where your distal interphalangeal joints are affected in rheumatoid arthritis. So now let's go through the other answer options. So the reason why it's not SLE, there's nothing really in there that points to SLE. So they don't have the rash. They don't mention any antibodies that are specific to SLE, anti-CCP specific to rheumatoid arthritis. B is wrong because this is a condition that's associated with meningococcal sepsis, where you get bleeding in the adrenal glands. So that's Waterhouse-Friderichsen syndrome. This is not reactive arthritis. Reactive arthritis occurs a few weeks or within a certain period of time of an infection, but this with all the other features that are involved in this question, you're thinking more of Felty syndrome as opposed to reactive arthritis. Frey's syndrome is just a condition which can happen after someone has a parotidectomy, so removal of the parotid gland. So the autonomic nervous system, which was supplying the parotid gland, instead of doing that after removal of the gland, they now supply the sweat glands in that area. So what happens is that whenever a patient eats, they sweat in that area of their face. It's very interesting, but not relevant. Anyway, so rheumatoid arthritis. It's a progressive polyarticular inflammation of small joints in the hands, wrists, and feet. So X-ray findings include loss of joint space, erosions, soft tissue swelling, and soft bones. So that would be less. So these are images. These are images which show some of the features of rheumatoid arthritis. I'm just wondering, sorry, Holly, is this recording by any chance? I think we forgot to record it, or did we stop?
It is recording.
Okay, great. Okay, I can't see it on my screen. Great. Okay, so these are images that show features of rheumatoid arthritis. So here on this one, you can see the swan neck deformities, where you get hyperextension of the PIPJs and flexion of the DIPJs. And here you can see subluxation and ulnar deviation. This one here is the opposite of the swan neck deformity. It's called the Bertonier's deformity. It's where you've got hyperflexion, you would say, of your PIPJs and hyperextension of your DIPJs. So it's just the opposite of swan neck. So these are some of the features of rheumatoid arthritis, and this is an X-ray which shows these changes quite well. This is with the subluxation. Great. So for the next question, if we can have the poll. Okay, we'll end it here. So this is a bit of a hard question, and it's a bit split between A, B, and C. So here we've got a patient, 35 years old, episodes of pain in multiple joints, photosensitive, well-demarcated rash on her face, experienced multiple episodes over the last few years, worsened with fatigue, myalgia, mouth ulcers. She's otherwise well, takes no other medication. So here, the most likely diagnosis that you're thinking about would be lupus. And the reason for this is all the pain in the multiple joints, the photosensitive, well-demarcated rash on the face, that should raise a suspicion for SLE, and the mouth ulcers as well. So we'll go through why the other options. So the correct answer is C. We'll go through why the other answers are wrong as well. So the reason why it's C is that in SLE, you get antibody complexes which are formed, and these activate the complement pathway. So complements are important in the process of opsonization, which helps in like phagocytosis and stuff like that. But in SLE, your complexes are activating this pathway anyway, and this results in the conversion of C3 and C4, which are inactive, to their activated forms. And as a result, you'll get a lower level of C3 and C4 in the blood. So that's why that's the reason why it cannot be A. And B is anti-CCP antibodies. It's for rheumatoid arthritis. Antihistone antibodies is positive in drug-induced lupus. In this case, this patient is not on any medications, and usually in lupus, you will not have a very raised CRP. It's actually quite low, or it's just not raised. Okay. So this is lupus. So as you can see, it affects like whole areas of your body, affects the lungs, the heart, the kidneys, causing lupus nephritis, affects your joints, your eyes, your nervous system as well. So it's got quite a widespread effect, and I won't really go into the details. You can read about that on your own. But blood tests, ANA, ANA positive, that's sensitive, but it's not specific for lupus. Anti-double-stranded DNA and anti-Smith antibodies, those are specific for lupus. And you can also have low C3 and C4 in lupus. And then, as I said, positive antihistone in drug-induced lupus. So next question, if we can have the poll, please. Lovely. All right, so most of you got this question right. The answer is D. So here, this is a patient who's had recurrent miscarriages, and we're suspecting antiphospholipid syndrome. And how do we how can we confirm the diagnosis? So the answer is D. So the reason is because you normally, for antiphospholipid syndrome, you need to have a positive antibody test on 2 occasions, 12 weeks apart. So B wouldn't be correct because it's just saying that it's been positive on 1 occasion. Lupus anticoagulant is also an antibody that tests for antiphospholipid syndrome, by the way. So A, previous preterm birth due to preeclampsia, not really, no. History of DVT and positive rheumatoid factor, no. This will not confirm a diagnosis. It might make you suspicious for it, but it wouldn't confirm a diagnosis. And P, following a surgical procedure, this can happen to anyone, not necessarily with antiphospholipid syndrome. So usually this occurs secondary to lupus, but it can be primary. It can happen on its own as well, but that's very rare. Features, you can look at the features using the mnemonics, so clots. So you get clots, mainly venous, but very rarely you can have arterial as well, it's like MIs and strokes. A rash called livido reticularis, and I'll show you a picture of this in a bit. Obstetric loss, so miscarriages and premature births, and then the thrombocytopenia is also associated with antiphospholipid syndrome. So you're using all the platelets, and yeah, so you get the thrombocytopenia. So investigations, we've looked at this, but these are 3 main antibodies to be aware of for antiphospholipid syndrome. And then management would be avoid combined pills, HRT, anticoagulation in patients who have experienced the thromboembolism. There is no indication to treat someone who hasn't had a thromboembolic event. If it's early pregnancy, you can give them low-dose aspirin and low molecular weight heparin together. And that is livido reticularis here. That's the rash. Okay, next question, if we can have the poll. Right, well done everyone. So most of you guys got the correct answer, which is C. So here we've got a patient who's got a red, swollen, painful joint, and they've got a background of hereditary hemochromatosis, and you can see chondrocalcinosis on the knee radiograph. So this points towards pseudogout, and reason is that hemochromatosis is associated with this condition, and very well known association. Great. So this is just a summary about gout and pseudogout, and we don't need to go through everything. Just things that I want you guys to just focus on is the joints that are affected. So in gout, it's most likely to be the first MTPJ, whereas in pseudogout, it can affect other joints like the shoulder, your wrist, your big joints like the knee joint as well. And then in terms of risk factors as well, it's very good to have an understanding of the different risk factors for both. In gout, things that commonly come up is the purine diet, the CKD, the thiazide diuretics. In pseudogout, as it did in this question, it would be the low, the hemochromatosis and the hyperparathyroidism. So in gout, you get something called needle-shaped negatively bifringent urate crystals on joint aspiration. And in pseudogout, it's the rhomboid-shaped positively bifringent calcium phosphate crystals. So this is just things that you need to learn and remember because they do come up in questions. Management, for pseudogout, you manage each episode with NSAIDs or colchicine, and there's no prophylactic treatment for pseudogout. But for gout, it has the same kind of management acutely, but there is prophylactic treatment like allopurinol, and there's criteria though to prescribe allopurinol for someone, and you can only start it 2 weeks after an attack or an episode has completely resolved, as it may worsen it. Great. So next question, if we can have the poll, please. Lovely. Okay, we'll just stand it here. Most of you guys got the correct answer, which is C. So let's just have a look at this now. So this is a patient, ongoing pain in the proximal joints, the hips and the shoulders, struggling to stand up from a seated position, stiffness in the joints in the morning. This lasts for about 1 hour before improving gradually for the day. So again, this makes you think inflammatory. His ESR is raised. So here we're thinking this is likely polymyalgia rheumatica, and which of the following is the most likely to be associated with the patient's condition? This would be GCA, giant cell arteritis. So how do we distinguish between, this is something very important, so how to distinguish between polymyalgia rheumatica versus polymyositis or dermatomyositis. So in PMR, you get inflammatory pain, you get stiffness of the shoulder and the hip and lasting for more than 1 hour, and that's the more prominent feature. Now there shouldn't be weakness, although that's quite difficult to test for when someone's in pain. It's quite difficult to distinguish whether they're actually weak or whether they're actually in pain and don't want to move because of the pain. But normally there shouldn't be weakness. For myositis, this is characterized by proximal weakness, but usually there is none or very mild pain. So that's how you distinguish between the two of them. And also in terms of the blood, you'll get an elevated ESR and PMR, whereas in poly or dermatomyositis, you would get elevated creatine kinase and some of these other tests here. So management, you give them steroids, bearing in mind that this is polymyalgia rheumatica on its own is not an emergency, so you can await investigations. For example, the raised ESR, the steroid workup as well, to see if they've got any comorbidities and like diabetes, hypertension, and things like that. DEXA scan for osteoporosis if indicated. In polymyalgia rheumatica, you would give a lower dose as well compared to GCA. Next question, if we can have a poll, please. Nearly there, just 3 questions left. Okay, I'll end it here. Most of you got the correct answer. Let's find out why. The answer is C. So this is a patient who's being investigated for progressive cough, shortness of breath over the last few months. The physical labs are stable. You have some tender erythematous nodules on the shin. So usually that makes you think of erythema nodosum. Her chest X-ray shows lymphadenopathy, and biopsy of these shows non-caseating granulomas. So here, the diagnosis that we're thinking of is sarcoidosis. And in sarcoidosis, you get a raised serum ACE level. The reason why the other answers are wrong, so let's go through them. So A, in sarcoidosis, you have high calcium levels, not low. B, Zeal-Nielsen staining is for TB. D, phosphate levels are not really relevant in sarcoidosis. And then positive anti-double-stranded DNA is for SLE. This is not SLE. The non-caseating granulomas, this wouldn't be a feature of SLE. It would be a feature of sarcoidosis. So again, it's a multi-system inflammatory condition. It affects your skin, it affects your nervous system, the glands, the heart, the lungs. It affects the whole body, essentially. And you get granulomas there around the hilum, and these are non-caseating granulomas. So chest X-ray. You can do a chest X-ray to stage the stage of lung disease. So stage 1 would be a bilateral hilar lymphadenopathy. Stage 2 would be this plus some peripheral infiltrates. Stage 3 would be just peripheral infiltrates, and stage 4 would be pulmonary fibrosis. Yeah, so that's sarcoidosis investigations. Next question, if we can have the poll, please. Okay, we'll end it here. Most of you got the correct answer, which is B. And let's see why that is. So we've got a 25-year-old man who's presented to the GP 6-month history of back pain and stiffness. And this is worse in the morning, gradually improves after about 1 hour, complaining of intermittently sore red eye as well, but this is not present currently. Blood tests show elevated inflammatory markers. So given the most likely diagnosis, what is the most appropriate initial management of this patient? So what do you guys think is the condition here? Lovely. Yes, it is spondylitis. Right. So, this patient is experiencing pain and stiffness in their joint. You wouldn't just give them physiotherapy, you would also want to give them analgesia. So that's why A wouldn't be correct. The B is physiotherapy and NSAIDs, and then biological therapies if they are not improving. So this would be the most appropriate management here. Steroid injection in the lumbar spine, definitely not initial management option. Reassure and discharge, you wouldn't do that. This patient has an inflammatory seronegative arthropathy. And then start with biological therapies, you would also not do that. Right, so this is a table which summarizes some of the seronegative spondyloarthropathies. So we'll just go through the angstbond, but in your own time, you can go through the rest. So these are the four main seronegatives. So they are negative for rheumatoid factor, but they are associated with HLA-B27. These are the conditions that are associated with HLA-B27. So with angstbond, it's more common in male, age 20 to 30. They present with inflammatory back pain, which improves with exercise. It's associated with uveitis, apical pulmonary fibrosis, or the upper zone, the upper lobe, aortitis, peripheral enthesitis. This would be like your inflammation of your Achilles tendon or plantar fasciitis. Bamboo spine on the x-ray. I don't have an image to show you this now, but if you just Google bamboo spine and you'll be able to have a look. It's quite typical for angstbond. The way you manage it is with exercise, physio as conservative, and then NSAIDs and DMARDs as well, like your methotrexate and your other biologics. Reactive arthritis, just briefly, occurs usually within 4 weeks of infection, and there's something called Wright's syndrome, which is arthritis, urethritis, uveitis. So I don't know if you guys have heard it, but there's a mnemonic called can't see, can't pee, can't climb a tree. So these are to remember, these three symptoms of the triad. Psoriatic arthritis would be associated with psoriasis, the nail changes as well, and it usually is associated with DIPJ involvement as well. So it's one of the seronegatives. You don't use hydroxychloroquine in psoriatic arthritis, and the reason is because it makes your skin, the skin rash worse. And then you've got your GI arthritis. So this question will usually include like bowel symptoms and then images of rash, or like descriptions of like specific rashes. And this will point to the answer. So final question, if we can have the poll, please, Holly. Okay, we'll end it here. Again, well done. Most of you got the correct answer, which is D. So this is the correct answer. So this is a patient who's been referred to respiratory because there is difficulty in controlling their new asthma diagnosis with inhalers. He has become unwell over the last few months, and he's having hematuria, and his blood tests show declining kidney function, and he's got his eosinophil failure on his bloods. So which of the following is the most likely diagnosis? So it would be C, eosinophilic granulomatosis with polyangiitis, or another name for it is Churg-Strauss syndrome, but we don't use that anymore. So this is just a summary or like very, very brief descriptions of what each of these conditions are, just enough to be able to help you answer questions essentially. But I would recommend further reading on these conditions and also on vasculitis in general. So Goodpasture's syndrome would normally be associated with pulmonary hemorrhage, so the patient might have hemoptysis in the question stem, and also renal impairment with positive anti-GBM antibodies. Granulomatosis with polyangiitis, this would be associated with a positive C anchor and anti-PR3. You get lower and upper and lower airway disease, saddle-shaped nose, and things like that. You get involvement of multi-organ systems. It's worth having a read about this. It was too much to cover in one session, and it's also associated with glomerulonephritis. Eosinophilic granulomatosis with polyangiitis, which is for this question, so it's associated with Pienka and anti-MPO. So associated with asthma, eosinophilia, and glomerulonephritis again. Microscopic polyangiitis, this is also associated with these antibodies. And then you have renal disease, pulmonary disease, and something in particular to remember that can come up in question is the peripheral nerve damage, so the mononeuritis multiplex, so with microscopic polyangiitis. And then you have Sjogren's syndrome. This is just an autoimmune disease where you get destruction of the salivary and lacrimal glands, and the patient has dry mouth. This is just dry eyes or like dry red eyes, keratoconjunctivitis sicca, and then you get like reduced mucus in the GI tract and stuff like that. And it's positive for anti-Ro and anti-La antibodies. I know this is very brief, but it can help with questions. And then I've also made a table with common antibodies for like different conditions. So in your own time, you can just review this. Some of these conditions we haven't covered in this lecture, but could be worth having like some brief knowledge about it. But otherwise, that's the end of the talk. Thank you very much. I would really appreciate it if you could please fill out the feedback form. Yeah, please. And that's it. Thank you for coming. Any questions? Holly, how's the questions been?
Yep, they've all been good. I think you've explained it really well, so there's not been that many questions. Just in response to someone who's just asked something in the chat, the next session is this Thursday.
Yeah. I hope this was useful, and I hope you have a great rest of your evening. You're welcome. How would you differentiate? Okay, Holly's answering. Thanks. Awesome. Great. Thanks, everyone. I'll just leave it on for one or two more minutes and then I'll end it. Unless there's questions coming in.
Ashka, sorry, could you just show the slide for question 9?
Question 9, yeah. Let me find it. The lupus one, this one.
Great.
Lovely. So we'll just end it here. Thanks, Holly. Thanks for your help.
No worries. Have a good night.
Thank you. You too. Bye. Stop share and